I'm Dave Walsworth. I'm an associate professor of family medicine at Michigan State University, College of Human Medicine, Department of Family Medicine. That title is impossible to get out on one breath. I'm also the associate chair for clinical affairs. And the next topic is pediatrics. This is part one, and we'll get about halfway through if we're doing all right. So we're going to start off with peds, kind of like the babies start off. What's the normal neonatal physiology? First of all, quick show of hands. How many people do deliveries in the audience? Okay, cool. Some of this is going to sound really familiar. How many people take care of newborns? More. Excellent. Okay. So this is all going to be a review. Babies breathe fast. 30 to 45 times per minute is normal for a newborn. If you or I were breathing 35 to 40 times a minute, we'd be on oxygen. They breathe through their nose, so it's important to keep it clear. If the nose is cruddy, they don't breathe very well. Don't be surprised when you see them breathing periodically. That's a normal pattern. Really, really fast for a little bit, and then not so much. And that can be present through the first several months. As long as it's not associated with cyanosis or other warning symptoms, it's normal. That's just what babies do. They're learning how to breathe. Their pathways are still getting laid down. Blue hands and feet, normal. Acrocyanosis. If it's around the mouth or central cyanosis, that's not. That needs to be worked up. Hands and feet, normal. What's the average heart rate for a newborn? It's the same as it is for when you're watching during delivery. Okay? 90 to 180, okay, 120 to 150, it's a lot faster than ours. If we ticked along as fast as the babies ticked along, somebody would try to put an overdrive pacer in us. Heart murmurs are very common. The ductuses sometimes close a little slowly. Work them up, but if it's just an innocent flow murmur, keep an eye on it. First stool, meconium. Hopefully it hasn't happened in utero. Okay, but it often does. Sometimes it's terminal, right at delivery, usually within the first 24 hours. Are we getting a lot of echo? Okay, I'm getting a lot of echo up here. And then the normal CSF should have 0 to 22 white cells. So always keep your normals in mind. Most of those are going to be lymphocytes. Hopefully you won't have to look so you won't notice. Normal feeding patterns. Breastfed babies, they're the most awake right after delivery. If everything's going well, get them to mom as quickly as you can. If mom's going to breastfeed, great time to start is right after delivery. Usually it's every 2 to 3 hours while they're awake, and they'll usually empty a breast in 7 to 9 minutes. Now, parents, how many parents in the audience? Okay. 7 to 9 minutes, we know examples that didn't work, okay? My oldest son could do 7 to 9 minutes, no problem. My daughter, more like 45. She was there continuously. We learned how to thunk feet. We learned how to wake her up. All the babies are going to be different. Some are very lazy eaters. Sleep for a half hour. Okay. So there are ranges of normal. What you want to watch for is, are things going okay? Is the baby growing? Is the mom and dad coping? As long as the answer to both of those is yes, we're doing okay. Okay? They may stop the middle of the night feedings pretty early, by 3 to 6 weeks, but others continue to 4 to 8 months, and others just keep going. And as long as they're growing normally, it's okay. The bowel movements, I wouldn't quite call it sweet smelling, but it's not nasty smelling either for the breastfed babies, that mustardy stool. And it's usually stringy and seedy. Now the formula-fed babies, it's usually 3 to 4 ounces every 3 to 4 hours by a couple weeks in. And an old rule of thumb that we used to use was about 1 ounce per week of life until you get up to an 8-ounce bottle. These stools aren't so sweet smelling. And babies will continue to eat. If you offer a perfectly growing breastfed baby a bottle after feeding, they'll usually take an ounce or two or more. Okay, it's not because they need it, they're growing fine. So that's something to watch for with the formula-fed babies. Since there's more of it available, they'll usually eat more, they'll distend their stomach, they get burpier, gassier, they can have more problems, and they may gain weight faster. So diet advancement, formula or breast milk until 4 to 6 months of age, that's the sweet spot. Start introducing things one at a time as you go on. Supplements for under 12 months of age, iron, if they're exclusively breastfed, they may need iron after 4 to 6 months, but guess what? They usually get plenty in the iron-fortified cereals they're getting. For low birth weight, you might want to do 2 to 4 milligrams per kilo per day, starting at a month of age. If you've got a breastfed baby, the iron that's in breast milk, there's not much, but it's very bioavailable. So it's not always the quantity, but it's the quality of the nutrient as well. Fluoride at 6 months, depending on what's in the water. Most water supplies are fluoridated if it's a municipal water supply. If it's a well, and only a well, and they're not using formula with nursery water that has fluoride in it or some other fluoridation source, they may need supplementation. Vitamin D, at least 400 IUs a day for those consuming less than a quart of vitamin-fortified formula or milk after a year, or 400 IU for the breastfed babies. So we talked about when to bring solids on board, 4 to 6 weeks. If you have an atopic kiddo, you may want to look at what you're bringing on when. You might want to avoid cow's milk or honey. You will want to avoid those less than a year. And anything that's hard, round, and about the size of a dime, don't give that to them. That's perfectly designed to block their trachea and cause a choking hazard. You might want to wait on egg whites, peanuts, fish until age 2 to 3 years because they're more allergenic. If there's a family history of allergy, if it's an atopic child, mom's atopic. If mom is breastfeeding, you may want to have her reduce those while she's breastfeeding if there's a history of allergy. Start with rice cereal before the wheat. It's easier to digest, and the gluten is more allergy provoking. If they're going to drink juice, that's fine, but it's in a cup only. It gets them out of the bottle, out of the sippy, it's in a cup. And then you can puree the foods because they don't have teeth yet. Vegetables, fruits, meats. And the order that you present is not as critical, but you want to present about 1 every week. And then watch the finger foods. So some common newborn findings, cyanosis. If you have cyanosis, it needs to be evaluated. The differential is wide. Something is not getting oxygen out to the parts of the body where it needs to be. So is it a congenital heart disease, a pump problem? Is it sepsis? The kiddo is under stress. Is it a neurologic or a pulmonary problem? You're not able to oxygenate the blood. So you want to start with your cardiac exam. Start with the pump and work out from there. Check your 4 limbs. Check 4-limb blood pressure, pulses. If the pulse ox, when you look at the pulse ox, it's usually going to be 100%. If it's not, then you can try 100% oxygen for 10 minutes. If the oxygen sat rises, then that's a sign that there's high pulmonary blood flow, and that helps your differential. Chest x-ray, EKG, all possible things that'll help. And then you may need an echo quickly. Transient tachypnea of the newborn. I think most everyone has seen this at least once or twice. It goes away. There's poorly ventilated lung with associated normal perfusion that leads to hypoxia because the lungs didn't get wrung out enough. They didn't get squeezed enough. The fluids didn't get out of there. Maybe more common in section babies as opposed to vaginal deliveries because you don't have the ringing. It's usually benign, self-limited, and treatment is supportive. Respiratory distress syndrome is the other side of this. This is not benign or self-limited. There's not enough surfactant, so there's too much pressure to open up the alveoli in the small passages. It's usually in the premature infants, and it's associated with hypoxemia because you're shunting. You've got a VQ mismatch. The treatment for RDS is surfactant and support. Prophylactically, if a baby's under 30 weeks, they're going to need surfactant. Depending on where you are, these kiddos may not be managed by us, but we need to know what's going on so we can see what happened when we get them back, and we can stabilize them until they get where they need to be. If they're under a kilo, they're going to need surfactant and ventilation. Over 1,500 grams, oxygen, CPAP, and then you see this, if you are needing more than 50% oxygen to maintain this child's saturation, they need surfactant. Persistent pulmonary hypertension, usually term or near-term infants, and it presents with tachypnea and cyanosis. Some of the things that should be cues that you might run into this: pneumonia, respiratory distress, pulmonary hypoplasia, meconium aspiration, or a congenital diaphragmatic hernia. Think about all the things that are going to interfere with lung maturity. You've got a toxin in your lungs, the meconium. You have your stomach in your chest. The lungs can't develop. Okay, meconium aspiration syndrome. This is where the infant has been stressed somehow in utero. They've had their first meconium stool or more, and it gets into the amniotic fluid, and what do kids do? They breathe amniotic fluid. So anything that's in the amniotic fluid is going to go in the lungs. It can occur before, during, or immediately after delivery, because the amniotic fluid is everywhere. What is meconium? It's the baby's first poop. It's all of the desquamated intestine, skin, vernix, bile pigments. It's thick, it's black-green, it's odorless, and it's sterile. It looks like little tar balls. What do? First thing is supportive. They need oxygen. You may need to assist ventilation to help inflate the lungs. Antibiotics if you suspect bacterial pneumonia as either a complication or part of the etiology. And in severe cases, surfactant. Again, if you need an FiO2 over 50%, think surfactant. Here's a great slide. Kiddo's got some weird movements. Is kiddo jittery or having a seizure? Seizures are pretty atypical in kids. We'll go into this a little bit more in a bit, but here's a nice side-by-side comparison. Probably the best is the jitteriness stops with passive flexion. Seizure doesn't. The jittery kid will have normal eye movements. The seizure baby won't. The jittery kid will be made worse if they're overstimulated. The seizure baby, not so much. And then the jittery baby will have tremors. They'll be tremulous, and more than just the lower lip, because I think everybody does that pretty quickly. Whereas there'll be clonic jerking in the seizure baby. The seizures in babies are not the usual seizures you see in adults. It's not generally the tonic-clonic jerking. It's more the staring spells, the automatisms, the lip smacking, the nystagmus, the bicycling with the legs, or apnea. It's a clinical diagnosis in this age group because the pathways haven't been fully put down yet. They're still developing. There's often no EEG correlation, which makes it really hard to figure out what's going on. And you will search for an etiology, but you probably won't find one. Okay, now, when you break these up, they fall into categories if you're going to try to figure out what's going on. Most of the CNS-based seizures are due to hypoxia, 30 to 65%. Intraventricular hemorrhage, common but not as much, 15 to 20, and then other congenital abnormalities. Infections are about 10 to 15%. Bilirubin is a toxin, kernicterus. This is why we watch for bilirubin. This is why we treat. This is what we're trying to prevent, but still pretty rare. Familial, these can actually be benign, where they begin on day 2 and resolve in 1 to 6 months. They're benign to everyone except the parents and the doc, who are both tearing their hair out trying to figure out what's going on, and then they back their way into this diagnosis. The treatment is try to find the cause if you can. If they're hypoglycemic, give them sugar. You can try an anticonvulsant, use the old ones first, phenobarbital. And then if there's a hypocalcemia, treat. Hypomagnesemia, treat. B6, antibiotics. And then the metabolics. If mom happened to be taking isoniazid because she was TB exposed or latent TB exposure, think about that. That's where the mom history is really important. Speaking about other prenatal teratogens, the symptoms are usually protean, irritability, poor feeding, tremulous. You could probably use those 3 symptoms to describe just about everything that can go wrong with a newborn. They're very nonspecific. With some of them, there are some things that tend to line up. Fetal alcohol will tend to have the smaller head, may have had intrauterine growth restriction, some facial dysmorphisms with the spacing of the eyes and the canthal folds, renal and cardiac problems. The cocaine-exposed babies may have more cardiac, skull, and GU anomalies. They're more likely to have an intracranial hemorrhage, and they may be more likely to have necrotizing enterocolitis. Perinatal HIV exposure, most of this is from vertical transmission from mom to baby. The best news is there's really effective ways to really minimize that transmission. Untreated, 25% of the moms will pass it to their unborn child. With treatment, we can cut it down to 2%. If we use retrovirals, C-section, and unfortunately this is the only time to recommend not breastfeeding that I'm aware of, unless you're giving medications that you can't give during breastfeeding. And there is research going on to look at certain agents given intrapartum as a last ditch to prevent. But the baby can be exposed previously. So we talked about bilirubin a little bit with seizures. Now we're going to go in and go through the whole pathway. First of all, neonatal jaundice is, we've all seen them, the little banana babies. They look anything from, yellow to almost golden yellow. And it's because of the bilirubin that's being put down in the skin because the primary pathway is overloaded, so the body's trying to get rid of it, and if it gets out to the sunlight, it can be broken down. So physiologic jaundice is usually mild, appears on day 1, doesn't go up much above 17 to 18, it's usually gone by 2 weeks in breastfed or by 1 week in formula-fed babies. Never really goes down below the belly button. You might watch it, but it's not a big deal. Early onset breastfeeding is a different type of physiologic jaundice, and that's usually because they're not eating as much right at first, they're not getting as much fluid, they're a little dehydrated, and if you keep feeding them, it actually improves. Breast milk jaundice, this is the second point. This is the 10 to 14 day point. That's why you see the baby at 48 hours of life. That's why you see the baby at 2 weeks. You're looking for these peaks in the bilirubin. You can, if they're breastfed babies, you can substitute formula and you'll see the bilirubin go way down for a few days. Put them back on, feed them, just watch it. If it's pathologic, there's some cut points, and we'll get to the nomogram in just a few moments. But if they're above 8 at a day, that's a bad sign. Above 10 at 36 hours, 12 at 48, and 16 at 72. History and physical, history and physical, history and physical. Everything in medicine and life is history and physical. Understand the risk factors that they brought to the table and that mom brought to the table. Look at the birth. Look at the tracing. Is there any evidence that there could have been birth asphyxia or that they've had a complicated pregnancy? Birth trauma, sepsis, diabetes in mom, hemolysis, delayed feeding, delayed first stool. Check the labs, and we'll go through a pathway in just a moment. It usually starts at the head and goes down. And then when it's clearing, it clears from the feet up. So you'll see that line moving from the belly button to the nipple line and gone. And if the jaundice is above the nipple line, the total bilirubin is invariably less than 10, or less than 12. Okay. So here is the nomogram. This is in most nurseries. You can get this on the internet. Harriet Lane is a fantastic source for this. But it gives you, are you at high risk, low risk, or somewhere in between based on the hours since birth. So when you're looking at this, if it's unconjugated, what's the differential? Is there a blood group mismatch? Are the minor antigens at fault? Is there an infection? An RBC enzyme problem like G6PD? Is there an RBC membrane disorder like spherocytosis or avalocytosis? If there's no hemolysis, is it breast milk jaundice? Does mom have diabetes? Or is there a problem with thyroid? Those are easy to check. For conjugated, when hemolysis is present, you're thinking more infection like CMV, sepsis, UTI, biliary atresia, or some inborn error of metabolism. Prevention. Again, we want to prevent damage to the baby's developing nervous system. We want to prevent kernicterus, and this is all designed to do that. Screening is every 8 to 12 hours while inpatient, just using the skin monitor. This is what most hospitals are using. Others still use the heel stick. U.S. Preventive Services Task Force has insufficient evidence to recommend universal screening. Most hospitals are still doing universal screening. And then prevention with frequent feeding, breastfeeding, 8 to 12 feedings per day in the first week, and formula feedings 1 to 2 ounces every 2 to 3 hours in the first week. So treatment, again, the body is putting this stuff out in the skin so that the ultraviolet rays from the sun can degrade it into something that's water soluble and will pass out. So it makes sense that the first treatment was to enhance the ultraviolet light. And you get these little babies that look like lizards on a rock in the little box with the little goggles on, and they're just soaking up the ultraviolet rays. Of course, you have to make sure that they're not getting dehydrated because they're losing a lot of water doing that. You have to make sure that they're nice and warm, but usually you have to make sure they're not too warm because it's pretty warm in there. Okay? For low-risk infants, with a bili level 2 to 3 below the recommended level, may be treated with conventional phototherapy at home.